Thank you. Thank you for the introduction and thank you for your invitation. So I will talk about value-based reform in primary care, well, payment reform of primary healthcare in Croatia. So why it matters? It really matters because we have unlimited demands and very limited resources, and it's not just in countries like Slovakia and Croatia, it's in every country in the world. This is why we need to, and also increasing burden of chronic diseases, fragmented care delivery, shortage of healthcare professionals, which really affects every part of health system. So from just buying services or paying for salaries, we definitely have to switch to strategic purchasing of services. This and primary healthcare as a foundation of every health system is the right place to start. So in general, the World Health Organization says when you start reforms, and especially payment reforms, always start with primary healthcare. So what we did in Croatia, I will show you in several slides. It was in 2013, but it is still something that is ongoing and developing, and our results are very good. So a little bit about Croatia. We have 3.88 million people, 64 hospitals, 37 acute hospitals out of these, 2,213 GPs. This reform that I will talk about was for gynecologists, pediatricians, dentists, and primary healthcare, and GPs. Family medicine doctors in Croatia, we have at least 50% specialists. So it's altogether 4,800 health professionals who were affected with our reform. We have one state insurance fund. This is different from your situation in Slovakia, and 7.15% of GDP spent on health, and also around $1,300 per person per year available health budget. Primary healthcare in Croatia has a very long history. Even Andrija Štampar, who was founder of one of the founders of World Health Organization, was Croatian, and he was starting primary healthcare, and he was emphasizing the importance of primary healthcare in Croatia. And in 1960, it was first specialization of family medicine in Croatia, in the world, first specialization in the world. So how our primary healthcare is functioning? We have free entrance. We have, as I said, 4 main specialties. We have 55% of doctors who are private doctors and 45% who are employed in 48 primary healthcare public centers, and who are on the salary. Then we have concept of chosen doctor and around 1,700 patients per GP. And they have very strict role as gatekeepers, because nobody can go to the hospitals without referral from GP, from family medicine doctor. And only family medicine doctors, only these GPs and pediatricians, gynecologists on primary level can prescribe drugs which are paid by insurance company. So they are actually gatekeepers. In 2013, we introduced this new model, so value-based care model. You can see the old and new. The old one had capitation. Most of it was capitation, like 90%, only 15 services, and 1% for administrative cost informatization. And new model has many different elements, which at the end are, if doctors are working well, can have a higher income. This was actually the reason why many of the doctors were very happy to sign new contracts. What are the parts? We have fixed part and variable part. In the fixed part, we have expenses, salary of a nurse, operating costs, drugs which are in the practice, and we have age-based capitation. So these are fixed costs, fixed part of the income of each doctor, which everybody is getting however they work. And this is how many countries still function. And what was revolutionary in this reform was this variable part, where we introduced fee-for-service. So it is diagnostic therapeutic procedures. We introduce around 200 procedures for example, for family medicine, preventive and curative. And we set the prices in a way that preventive are a little bit higher prices, so that doctors are motivated to do preventive checkups. Then incentive part, which key performance indicators, quality indicators, and some additional possibilities, 5+, which are prevention, group practice, and 5-star practice. I will tell a little bit more about it also. So which KPIs we introduced? This is very important. We introduced prescribing prescription drugs, sick leave rate, referral to laboratory, referral to hospital. And how we introduced it, we checked a year before all doctors, then we set the median, and we said if you are below, you will be paid. If you are above, you will not be paid. In a sense that we would like to keep our patients on primary level and not send them to hospital, because if we send them to hospital, the costs still multiplying, and there are many situations when patients are sent to hospitals without real need, and they can be kept. In UK, for example, 84% of everything that comes to primary healthcare stays in primary healthcare. So only 16% of all the situations is referred further. So also referral to laboratory, what doctors previously did. They say, okay, for a patient, do this, and this, just like that. And when we introduced this referral, and when we said you will be paid if you refer less to laboratory, they picked, I want CRP, I want leukocytes, I want this, and we decreased 20% in 1 month referring to laboratories. For quality indicators, we had clinical indicators. We have in specific areas like hypertension, diabetes, COPD. Like, for example, patients with diabetes in care who have HbA1c below 8. Organizational indicators, peer groups, antibiotics use. For 5 stars, so you can see additional, if they are filling in preventive panels, if they are in a group practice, if they are 5-star, and we even put them a stamp with 5 stars, like 5-star hotel, and we said, if you are providing these 5-star, these services, you are 5-star practice, and they all wanted to be 5-star practice. You can see which were these special services that make them 5-star. For group practice, this was the first time that they actually started talking together with each other. So it's a group monovalent. It means it can be only on GPs or polyvalent GPs with gynecologists, with pediatricians. And then they can horizontally refer their patients to each other based on their special skills. And practices can be like 5 kilometers and in special cases 10 kilometers apart. And they have peer groups together where they can once a month be paid to discuss some special case and receive points for renewing the license, which at the end they didn't need to go to some pharmaceutical conferences. They get their points only with peer groups. This was the innovation for non-communicable diseases management and prevention. These are very simple panels developed by doctors for themselves to easily manage chronic diseases. And this was recognized by World Health Organization as best practice and sent around. What is very important, this was not designed by Health Insurance Fund, but by doctors themselves. Our results were very good. You can read here, I will not read it, but we really increased quality and and we enhanced medical outcomes. We will share on the panel the key messages for Slovakia. Thank you.
Thank you as well.